So I am Ian Stokes of the University of Vermont, and the topic for today, innovative imaging for adolescent idiopathic scoliosis, and addressing these innovative techniques of radiography, ultrasound, EOS, and artificial intelligence. So first, we should ask, what is the purpose of imaging? How can imaging be used? It's currently used for detecting and quantifying spinal asymmetry. It's used in differential diagnosis, for instance, in finding vertebral spinal cord anomalies, other possible causes of the asymmetry, monitoring progression of detected curves, and evaluating treatment. But there are many challenges for increasing the the uses of imaging, in particular, drawing attention to prediction of progression risk and predicting treatment outcome. So we have to ask, why are we stuck with a 75-year-old Cobb angle as the standard measure of scoliosis? Can we do better than that? Well, EOS offers some advantages. It's effectively no parallax, infinite film focus distance, so no distortion. Slow dose, that's good. It uses biplanar images, and from those it's possible to extract three-dimensional measurements in three principal planes, and with image feature recognition combined with prior knowledge of anatomy is able to make reconstructions of skeletal shape. Well, there are many efforts being made to automate the recognition of features in these radiographs and derive measurements such as wedging and curvature. So is this artificial intelligence, which is basically machines replacing or augmenting humans? That's scary, of course, because impersonating humans is bad. But many algorithms being developed here using learning-based edge detection to identify vertebral bodies in a lateral view. Here, automated model-based vertebra detection, identification, and segmentation in CT images. And here, a two-step deep learning model for landmark localization in this case, lateral spine radiographs. I think the challenges are generally greater in frontal plane radiographs. And here, using machine learning to automatically measure axial rotation of vertebrae and radiographs of adolescents with idiopathic scoliosis. And beyond that, could ultrasound imaging with detection of features replace radiography without ionizing radiation? Brink and colleagues performed a reliability and validity study of measuring coronal angles from ultrasound imaging compared with radiographs, and found a very reliable relationship between the two methods, but of course with a systematic difference, because from the ultrasound they were using the midline of the spine curvature measurements from that line, which we know is systematically different from the Cobb angle measurement of vertebral end plate angulation. But there is a relationship which can be compensated for. So this is a promising replacement, at least for measuring spinal curvature frontal plane using ultrasound. So do these image processing algorithms and machine intelligence improve patient care? They provide potentially easier and faster measurements of skeletal shape. They provide multiplanar measurements and potentially detect difficult to identify features that might be missed by radiologists. So anything else? So, well, first, what is artificial intelligence? Machines replacing or augmenting human abilities. Wikipedia gives some examples, which include advanced web search engines, understanding human speech, self-driving cars, and recommending which Netflix videos you might want to watch, and competing in strategic games such as beating chess grandmasters. So IBM gives a definition of a branch of artificial intelligence. Machine learning is a branch of artificial intelligence and computer science which focuses on the use of data and algorithms to imitate the way that humans learn, gradually improving its accuracy as more data and observations become available. So if artificial intelligence can do all of that, what can it do to improve understanding and management of people with scoliosis? So we're familiar with developing databases of information about patients and then conducting statistical analysis, initially descriptive, then finding differences between groups or differences over time, relationships between measurements and clinical observations and groupings of patients. And this potentially with the idea of predicting what will happen to an individual based on observed trends. Machine learning offers an automated way to adapt to new data inputs. So can artificial intelligence using large databases and other knowledge about scoliosis help clinically to predict curve progression and provide prognosis for treatment? Well, first, so what image-based information should be included in that database? Here was an attempt to incorporate several measurements, geometrical measurements, into an analysis. Cob angle, also apical vertebral rotation, the level of curve apex, rotation of the plane of maximum curvature, and that for an upper curve and a lower curve in each patient. And that these measurements were then analyzed using a cluster analysis to identify groupings of patients, all of whom had adolescent idiopathic scoliosis. And there were, based on this cluster analysis, 4 actually very distinct groupings identified. And the most significant, most important determinant of which grouping a patient would be assigned to was the polar angle. That polar angle actually being one we developed for this purpose. It was essentially the relationship between the plane of maximum curvature in the upper curve and that in the lower curve. So a compound measurement of planes of maximum curvature. And the groupings were quite distinct. Here, for example, between group 1, which was predominantly left lumbar, right thoracic curves, and group 3, which was predominantly right lumbar, left thoracic. And in the axial plane, the plane of maximum curvatures were distinctly different, and perhaps as expected for these different curve types, the plane of maximum curvature being rotated in opposite directions. So here, Doncelli and colleagues wrote a provocative commentary identifying predicting scoliosis progression as a challenge for researchers and clinicians. Can we rise to that challenge? Of course, it's important because identifying progression gives the opportunity for early intervention when a curvature is small, and the treatment can then be used at an early stage to prevent progression to a larger curvature. But to do that, one needs to know that that patient would have progressed without treatment. Well, so actually from Hong Kong, a study using several measurements to identify the risk of curve progression. And so several measurements were included and shown here as receiver operating curves. And starting at the end, they incorporated 2 circulating markers from serum, actually measures of microRNA associated with bone metabolism. And they were useful in this model of predicting progression up to 40 degrees Cobb angle. Also, of course, Risser angle was a helpful component of the prediction. Body weight was incorporated because of its receiver operating curve. Menarchal status, of course. Not surprisingly, initial Cobb angle was a risk factor for progressing to a larger curve. And the composite model, top left, its receiver operating curve showed an impressive ability to identify the risk of progression. So, and this is a study from Nault and colleagues in Montreal. They developed a predictive model of progression using measurements from radiographs, and they found that significant predictors were initial skeletal maturation, curve type, frontal Cobb angle, angle of the plane of maximum curvature, and 3D disc wedging. So with that set of measurements, they could achieve an impressive level of predictive power. So what about the future challenges? It would be good to make use of these innovative techniques, AIS, imaging methods, AIS, MRI, CT, but they are expensive. So should we go back to the roots of IRSSD and focus on ultrasound and surface topography, less expensive, and no ionizing radiation, and portability is an advantage too. So, but then the big challenge, can artificial intelligence and human intelligence use large databases of images and clinical history in order to identify the best measurements and clinical observations from imaging and clinical observations, the best ones to include in the database, and then focus on how to improve patient care, to get easier, faster measurements, to get multiplanar measurements, if those are useful, and to detect difficult to identify features that might be placing that patient at risk. But ultimately, I'm proposing that the major goal we should focus on is predicting progression, and that would allow to predict treatment outcome and identify patients who would benefit from early intervention. So I hope those comments are interesting, provocative, and helpful. And I look forward also to hearing the other presentations at this virtual meeting. Thank you.